Hey, ladies, welcome back to today's episode. I'm so excited to be joined by Dr. Nadia Sirdar. We are going to talk today all about how we can talk to our primary care docs about menopause. Menopause is still one of those taboo words in our social circles. And sometimes, as we're going to talk about, even in the doctor's office, it's a bit of a taboo word. So, we're going to get into how we can feel comfortable with having this conversation. Dr. Sirdar, welcome to the show. You are an internal medicine doc in Bethesda, Maryland, so kind of in that DC area. Welcome here. If you would just introduce yourself to the audience and then let's get into some questions.
Thank you so much for having me. So I am American Board of Internal Medicine trained and spent the last 10 years working as a hospitalist at Sibley Hospital, which is a Hopkins community hospital. And there I really saw kind of very much like end stage disease, very complicated cases, people that were really having a hard time. And I kept thinking if they had had better care before they got there, maybe we could have prevented it. So I've shifted my focus. I started a direct primary care practice, and my focus is on prevention.
Absolutely. And I'm so excited to learn more about your direct primary care practice as we continue the discussion. But you make such a good point, and that is the importance of primary care. And that's one
Right.
of the, important reasons that I wanted to start this podcast to really talk with women about how we can not only treat disease when it occurs, but how we can prevent disease. And that's so important in what you and I do in our practices every day. So kudos to you for the work that you're doing. And I'm excited to hear about your new private practice also.
Thank you.
Well, let's talk about menopause a little bit and let's kind of
Yeah.
start off with the basics. Why do you think, I know that you deal so much in your private practice with women who are in the perimenopause and menopause stage of their lives. Why do you believe that so many women feel their concerns about menopause aren't fully addressed during their primary care visits? Because we certainly see that happen.
Sure. So, one of the number one things that is really kind of concerning and difficult for patients is when their physician um, doesn't feel prepared for the conversation at all. So,
Yes.
when we started our training, whatever it was, 15, 20 years ago, the data came from the Women's Health Initiative in 2002, and it showed that there was increased risk for women to have increased risk of stroke, breast cancer, other sort of negative effects of hormone therapy. And so essentially, as physicians, we take that very seriously. And, first thing is do no harm. So even folks that were legitimately on hormone replacement therapy, everyone just kind of stopped and it was full stop. Throw it away. It's bad for you. It's dangerous. And then, fast forward to now, when you talk to your primary care doctor, they may be in the mindset that they trained in, right? That this is not something that is appropriate or safe. B, they may be starting to sort of tiptoe into the new information that's coming out there, but maybe they don't feel comfortable because most of us, if you're seeing, 20, 30 patients a day, you're not going to have time to go do a CME or do a course. And then number three, I think it's sometimes has to do with the demographic, frankly. I think some of the older docs may be leaning towards more male. Maybe they don't have as much experience or as much comfort talking about the symptoms of perimenopause and menopause. And I think all of those things sort of combine to like a perfect storm. So the patient ends up feeling a bit shut down and a bit of like medical gaslighting, not on purpose by any means, but I think it's just a combination of all those factors.
You're right. And I think that combination is real. I've gotten to the point in my own practice in the last, year or so where I have just had that conversation with women that if they had asked me 5 years ago in my practice about, hormone replacement therapy, I
Hmm.
would have shut it down. I would have
Right,
completely shut it down and said,
right.
no, you don't need that because of this, this, and this. And I've done
Correct.
that. And at this stage of my career, I'm almost embarrassed, Dr. Surdar, that I've done right that it goes back to kind of how we were trained and we had this
Right.
long list of things that hormone replacement would cause in women, and I think
Hmm.
we were just leaving women to be miserable. We'll talk a lot about
Miserable.
the symptoms. Yeah.
And I think, not to blame our poor mothers, but a lot of times we get information from our families. So our mothers, our aunts, our older sisters, they might say, oh, yeah, I went through that and that wasn't a big deal. So why are you making a big deal? Right?
Yeah, yeah, it's not a rite of passage. You don't have to
Correct.
be miserable and the second menopause. So to my audience,
Yeah,
take this away that you shouldn't let older women in your lives make you feel
I know.
stand for
A
not wanting
shame.
to do it. And you also shouldn't let your physician, right? I mean, let's be
Correct.
clear. You shouldn't let
Yeah.
your physician not want you to do hormone replacement therapy if they don't have a good reason to back it up. Now, there's still perhaps some people who truly
Sure.
should not have hormone replacement therapy, but it can't be that one size fits all, no one should
Right.
have it, which is how, unfortunately, we were trained. And so there's such a shift happening now that I think is really exciting. Tell us a little bit kind of about that shift. I know you
Absolutely.
recently wrote about the lack of formal
Yeah.
medical
So
education. Let's talk about that.
absolutely. So, one of my passions is to sort of try to fill the gaps that exist in our own primary care training with regards to caring for women in perimenopause and menopause. And the way I like to break it down is, you have bone health, brain health, and sexual health, right? And it's a systemic issue. And so, really, what I would love to do is sort of allow the physicians who are in primary care practice to have kind of a bullet point list of symptoms, review of systems, looking at clinical, because the big thing here is it's a clinical diagnosis. So,
Mhm.
especially in perimenopause, you think about your hormones, they're kind of sputtering. Everything's going up and down, up and down. So, if you're measuring something on a Monday, then maybe on Tuesday or Wednesday it would be
Yep.
different. And so, Monday you're on perimenopause, Tuesday you're not. So that's not very helpful, right?
Right.
And it's important for us to make sure that we understand what symptoms our patients are going to come in and complain about. Having said that, what I have found really helpful is reaching out to other specialists and saying, what are you seeing in this age group? So, ear, nose, throat, rheumatology, endocrinology, all the folks that are in the subset of internal medicine that I would normally, refer out to. I'm just saying, what do you do in these situations? What can I do better? And what can I take care of in house without having to refer out?
Right. I love that. And that is such a great way to kind of meet those patients where they are as well.
Hmm.
So, for women who are listening, who are in their 40s and 50s and are starting to notice some changes, what are some of
Right.
those key symptoms or clues that they may be having that may kind of make us key in that they're in perimenopause or menopause? I love that you brought up that it's a clinical diagnosis, meaning we
Mhm.
don't have to have labs. So often patients will come in to my clinic and want me to check their,
Sure.
hormone levels to see if they're in perimenopause.
Right.
But I love how you bring up that it's so clinical instead.
Yeah, so absolutely. So one of the biggest things I get complaints about is sleep. So I think I posted this recently on my own Instagram because I fall asleep just great, and then I hear my patients say that they wake up out of the blue for no reason, 2:30 in the morning. For me, it's 2:37 a.m. or 2:27 a.m. It's like that window of time, and you wake up and you're totally awake, and there's nothing to do. You can't read. You can, I mean, you can do all you want, but you're not going to fall back to sleep. Um, so I think the sleep disturbance is a big one. And obviously when you're low on your sleep, it increases your cortisol, increases your stress hormones. You may want to overeat. You're dragging through your day or having your extra cups of coffee, and it's cyclical, right? So you have the sleep debt. The other thing is this sort of brain fog or this cognitive slowing. I like to compare it to, when you have like, oh, I was just thinking about something. I had my train of thought and then I lost it.
Yes.
And
Yes.
and you have the word, but it's on the tip of your tongue, and now you're mid conversation,
Yep.
and you're just trying to get your thoughts out, and it's very disconcerting because a lot of us feel very, like we're mid career, we're established, we feel like in a professional setting, no can handle pressure, but then you start to like stutter on a thought, and
Mhm.
and that's sort of like that cognitive slowing. I think can be very disturbing to a lot of women. And then, of course, the bone health, that's a little bit more clinical. But, when people have a history of, osteopenia or osteoporosis in their family, they may want to sort of talk to me about how can I make my bones better prepared for aging.
Right.
So those are but I think the biggest symptoms that I've heard about complaints are sleep, the cognitive slowing, and another one's the weight gain. A lot of abdominal, sort of visceral obesity around the middle section. So they'll be eating healthy, going on their daily walks, working out, doing everything right, and yet somehow they keep putting on weight right around the middle section of their body.
Right. That's absolutely a big one. Those are certainly all the ones that I hear in my clinic
Hmm.
as well. The scenario in my clinic, usually though, and I know that this is probably the same for a lot of
Sure.
care docs that will have patients who are on the schedule for problem XYZ. And so
Right.
we're going through problem XYZ. We're at the end of the discussion. I
Right.
ask if there are any more questions because I'm still that way, and I love to
Yeah.
make sure that my
Sure.
patients get all the things out. And boom, that is when the question hits, right?
Right.
And so it's
Absolutely.
all those things that come together, the sleep changes, that visceral kind of abdominal fat, the
Mm.
decreased sex drive, those things that come. And I know in my head I'm starting to put the pieces together.
Yeah.
It sounds like perimenopause
Sure.
that were there, but sometimes those questions don't come. Sometimes
Yeah.
ladies are embarrassed or
Right.
ashamed to ask those questions. And so what advice
Hmm.
do you have to ladies about how they can start to, bring up that discussion with their docs?
Absolutely. So one of the things I think that's very helpful, I'm somebody who likes to write things out. But whether you put on the notes of your phone or write it out, I think it's important for you to sort of think about the symptoms that are creating changes in your daily life and are impeding your daily life, and to say to them, the physician that you're meeting with, these are the symptoms that are happening this many times a day or a week.
Mhm.
And this is how it's impairing my sort of daily life. And I think when you hear from the patient the exact symptom, the frequency with which it's happening, and how it is impeding their lifestyle, I think then it becomes a question of A plus B equals C. And what can we do to make this better?
Right.
Right.
Absolutely. Absolutely. And I love just that idea. One of our previous episodes was just about that preparing, how to prepare for your doctor's appointment, right?
Right.
One of the
Absolutely.
things, yeah, one of the things that I spoke about and that I encourage even my patients to do is to jot down some questions before you come in.
Right.
Jot down things that if we don't discuss this before you leave,
Yeah.
then it has been a failure of
Right.
a visit. And now that doesn't mean I'm still an insurance-based practice. And so you have the luxury of more time with your patients in your practice, which
Sure.
I want to talk about. But that doesn't mean you can bring a list of 25 things. We're not going to hit on
That's right.
those, but
That,
thinking about those things that we really need to discuss. And if there's symptoms that are enough that they really are impeding your life, it doesn't have to be you tagging it on to another appointment. You can go in
right.
just to have a discussion about that.
That's exactly right. And I think another thing that's really important is that, when we talk about hormone replacement therapy, that's something that is catching a lot of buzz right now, but there are non hormonal therapies out there, multiple options to help with symptoms. And so I think you just need to be able to have that guidance from your primary. And frankly, if you don't get an answer that is acceptable to you, it's okay to say, I'm okay if you're not comfortable with this
Yes.
section of these questions, but could you kindly refer me to somebody who can address it? Do you know a perimenopause or menopause specialist? And that's one thing that I think is important for folks to know about. The menopause certification, some of us can do. I'm studying for the exam for June, but it's really nice because it's almost like a sort of regimented way of learning the data and becoming certified. And then women can find physicians through that database.
I love that. And that was going to be one of the next things that I asked you is what
Yeah.
do you recommend women do when they get, one of a couple things? They either get that blank stare from their doctor,
Yeah.
or even worse, they get what I've just said. I used to tell women 5 years ago, this,
Sure.
very quick, very,
Yeah.
matter of fact, you don't need hormone
Right.
replacement. It's one of those things that women go
Sure.
through. So that's what I was going to ask is that what do you encourage patients? Because in my practice, I do just what you just said. I say,
Yeah.
if you'd asked me before, I would have brushed this off, and I'm embarrassed
Sure.
to say I would have brushed it off, but I won't do that today. But I'm still
Yeah.
not at a place that I've not done the training that
Right.
I have to do really soon. And I love
Right.
the training that you're doing, but I've not done it yet. And so I work
Yeah.
really hard to find a physician who is comfortable with it
Absolutely.
for my patients. But what advice do you have to patients when they don't get that from their primary doc?
So one of them was the resource, the North American Menopause Society has like a certification system, and they have like a database of all the physicians that are certified. So I'm not technically certified yet, but I'm on
She
my
will be
way.
soon, ladies. She will be soon.
But and I also think when you're interviewing for a new physician, so in my world, direct primary care, that relationship between the patient and the physician, I always give a discovery call to everybody, that's like a no pressure way of chatting. And what I tell them is this really isn't about all the medical stuff. It's really to figure out if there is a connection here, kind of like dating. Do you feel comfortable with me? Because if you're not comfortable, you're not going to tell me really intimate details of your life, and you're not going to feel really comfortable for me to ask about, right? And so I think part of it is if you're going into a setting where you have the choice, it's helpful to ask those questions ahead of time. But a lot of patients don't have a choice. They get assigned a primary care doctor according to, you know, um, who has a room in their schedule. And I think for those people, I think it's helpful to sort of ask them in real time. And then if you're not happy with the answers that you're getting, to sort of do your research and find out physicians in the area who do see specifically for perimenopause.
Absolutely. And I think that that is our right as patients, right? And
Yeah,
you're so right that sometimes insurance will say, well, this is who you're assigned to, or a
right.
practice will say, well, this is the only doc that has availability. But I encourage
Sure.
my listeners to push that a little bit, right? So push
Yeah, absolutely.
to really find a doc that you feel comfortable with and that you are comfortable asking those intimate questions to, because
Right.
that's how we reach our best health, right?
Absolutely. I actually had a really fantastic experience. I'm shadowing somebody much older. I think he's in his late 70s, and he's one of the physicians that kind of wrote the book on menopause.
Oh,
And it's amazing to shadow him and the just the sort of watching how he asks the questions. There was one patient who came in and said, I've had terrible fibroids, and I'm going to have them removed, and I really want to know how that's going to affect my sex life. I've been married 45 years, and I don't want that to affect it negatively. And he asked a sort of what I thought was a bit of a shocking question. He said, well, do you orgasm from cervical stimulation? And he looked at me funny, and I looked at him funny too, because I was like, well, that's not a question I've ever asked a patient. But the
mhm.
reason he was asking was because he wanted to ask her, should she have a cervical sparing surgery?
Ah,
Because
right.
if we don't think about that, then we could be sort of catastrophically affecting her
Right.
sex life and her relationship with her husband. So things like that are subtle. I think that type of conversation only happens with someone you really feel comfortable with, right?
Absolutely. And establishing that comfort with the patient is so important to us as physicians.
Right.
To the patient, if you are there and you realize that this is not about
Yeah.
your physician at all,
Right.
I'm begging you to go find another,
Yeah.
right?
Well, and the other thing we worry about too is if we don't put importance on it, then the patient kind of feels a little sheepish to even ask.
Exactly.
Right.
Exactly. Which is why I love how there's such a push now back towards, hey, docs, let's back up and
Yeah.
maybe hold with a grain of salt some of those things that
Right.
we were taught in our training, and let's
Right.
really, get to where we better understand perimenopause, menopause
Absolutely.
that our patients are having. Dr. Serdar, what do you wish, if I gave you a wish of what you wish more women understood about menopause, would you share
Yeah.
that with us? And then would you share what you wish more primary care docs knew about menopause and perimenopause?
Okay, I love those questions. Okay, so what I wish my patients knew about perimenopause and menopause is that the sooner you seek treatment and the sooner you get on the hormones, if it's indicated, the more sort of there's a greater benefit the earlier you start, essentially. And the data is sort of coming out slowly but surely out of every different field, whether it's protecting your
Hmm.
brain from Alzheimer's potentially, or
Heart.
protecting your bones, heart health. Um, you know, if you have cardiovascular prevention, you're preventing the strokes, you're preventing the heart attacks. And some would argue that even if you um, don't meet the criteria, there's a nuance there that you can sort of look at people's risk reduction. So I would say don't take it off the table if you're having symptoms as early as 35, 37, 38. Some people have their children in their late 30s, and then
Mhm.
they're crossing 40 and they're having those symptoms. I think it's really important to look at it and not sort of brush it off for a really long time. And
Right,
then, later on it might be helpful, but not as helpful.
right.
Um, I think that's a big one. And then your second question
The second
was,
question was, what do you wish other primary care docs knew about perimenopause and menopause?
so I think the big one is kind of the symptoms. And when you're going through a review of systems, to think about, are they having cognitive slowing? Ask about, do they have vaginal dryness? Do they have increased frequency of UTIs? Do they have pain with penetration? Are they finding that they're gaining weight regardless of what they eat or how much they exercise? Kind of like just adding like another layer of nuance to the normal questions we ask. So
Mhm.
it's not really sort of revolutionizing how we do a
Right.
history and physical, but it's
Right.
just adding those couple, three, four extra questions to say, is this some path that we need to go down, right? If
Mhm.
somebody says to you, actually, I've had a UTI every month for the last 6 months.
Right.
Oh, that's interesting. We need to
Yep.
get in there and do an exam. Do you have vaginal atrophy? Do you need
Mhm.
topical estrogen, right? So, but if you don't ask in that review of systems, I think it becomes like hopefully she'll say something. Hopefully I'll say something. If we
Right.
don't get to it, our visit's over and then the
Right.
chances up.
Absolutely. Absolutely. And so that encouragement I love from you is just for both patients and physicians to really be more open to the conversation, be more open to the
Right.
conversation. We know that women are having these symptoms. We know that as physicians that we've got treatment options there. It's just a matter of the two getting together and making that,
Exactly.
that connection. Dr. Sara, thank you so much. I'm going to give you that last word on perimenopause and menopause. But first, I wondered if you would tell us a little bit about your practice and what you're
Sure.
doing and where listeners can find you.
Oh, well, thank you. So my practice is called Bethesda Modern Primary Care. And I somehow got lucky and got the website BethesdaDoctor.com. So they
Wonderful.
can find me on that. And what this is a direct primary care practice. Essentially, it's a membership based model. And so you pay for the year. I think I have a yearly and semi-annual and a quarterly. But the idea is to take out of the picture the middleman, right? So it's me as a physician. I have a micro practice, and when somebody calls the practice, they're going to talk to me or my nurse manager, talk to me the same day, visits, same day, next day, and really to try to create a relationship where we have time. And
Mhm.
the time is not a pressure. So you don't have to put your hand on the door to leave and then tell me all the 10 things that are wrong. Rather, we can sit down calmly and talk about things one by one. And there's no pressure to come in. I mean, you can come in up to 5 times, you can come in more if you need to, but essentially, I want to meet my patients where they're at. So
Mhm.
a lot of my patients thus far are very busy professional women. They're working mothers. They have the sandwich generation where they're taking care of their parents, their
Right.
children, spouses. You're taking care of everyone else and you're sort of last on the list. And
Yeah.
my role is to be their quarterback and to be their advocate and to say, listen, I know you're really busy, but you must come in or we must do this one test to make sure you're safe.
Right. I love that. And I know that you're building an incredible practice. And I know that you're such a
Thank you.
wonderful resource for your patients. You have some social media also, Facebook and
I do.
Instagram. All right.
I do. I was a little shy about social media, but I finally have put myself out there. It's my Instagram is at Dr. Nadia Sirdar, and then Facebook same. And I like to just offer, educational sort of pieces of data, just anything that's coming out. I like to sort of translate it, if you will, in
Yes.
little tiny 20-second sound bites, because I think what's really important, Brittany, is that we have to make a change with the source of information. So
Mhm.
everyone is trying to get out there and get a quote piece of the pie. I think it's a popular topic right now.
Mhm.
But there's a lot of folks that are maybe like they might be creeping outside of their scope of
Exactly.
practice. And I
Exactly.
think it's important that we talk about evidence, we talk about the data, we talk about what's safe, and that your MD or DO or, physician who's sitting in front of you who knows you is the one that's making those decisions together, that shared decision making with the physician. Really, I think that's the part that I really think I feel strongly about.
Absolutely. I think you're so right. And I love the way, even just in our conversation today, you're able to take this big topic and put it into terms and
Thank you.
into a discussion so that we can all understand it. Dr.
That's
Sardar,
okay.
yeah, Dr. Sardar, we're going to give you the last word here. If there's anything that you'd like
Oh,
to share,
okay.
just as we close, we'd love to hear it.
Oh, wonderful. Thank you. I think I just want to say, physicians want to do right by their patients and we want to serve you. And I think the best way to do that is to put ourselves out there and let you know that we're here. And, if we have that partnership in care, I think that's the best thing for the patients and the doctors.
It has been such a joy to have you on the show today. I love being able to produce this podcast for women who, just as you said earlier, we all lead really busy lives where, trying to work as
Right.
hard as we can. We're taking care of our children, we're taking care of our parents, we're doing all the things, but are at this place in our lives where we really want to and need to focus on taking care of our own health as well. And so, thank you for your time and for breaking down this topic
Thank
for us.
you.
And we wish you all the best in everything you do.
Thank you so much.
I'll be here next week with another episode. We'll talk to you soon.
Thank you. Take care.
Hey, thanks for listening in today. I hope something you heard in this episode will help you on your journey to becoming healthier. Remember, this podcast offers general health information. I am not your personal physician. If you need advice that is specific to you, be sure to consult your physician. If you enjoy this podcast, please consider sharing it with a friend and reviewing it on Apple Podcasts. Also, be sure to subscribe to the show so you never miss an episode. Tune in next week for another great episode of Headed to Healthier. Until then, take care of yourself. Talk soon. Bye.